Thank you very much for joining this meeting. The whole series of these meetings has been organized by Professor Steve Thornton. We have the support, of course, of the Fidelity Foundation. I'm very sorry for many people that were unable to register because we were only allowed to accept 1,000 registrations, and those were filled in within seconds of us making an announcement. But for the next webinar, we will open up the program for 10,000. It's a great honor and pleasure for me to invite Professor Christoph Liss to be the starter of this series of webinars, and he will cover both preeclampsia and his extensive work on fetal growth restriction. He's a professor at Imperial College, a good friend and colleague for many years, with extensive research in both of these areas of his topic of today. So, Christoph, you have to unmute yourself, Christoph.
Yeah, that's elementary mistake. Thank you very much. Thank you very much, Kipros and Steve, for inviting me here today. It's fantastic to see 1,000 people, which is 998 more than normally join my lectures. So welcome everybody from wherever you are. I am going to talk about preeclampsia and fetal growth restriction, and I thought I'd throw in a little bit about biomarkers as well. So I'm talking about the truffle studies and whether truffle studies fit within international guidance, and the emerging area in the last 5 minutes of biomarkers, fetal growth restriction and SGA, because there's been an interesting paper just out in the last few days on that. So let me, without further ado, start my slideshow, and I'm very much hoping that you can see slide 1. So, as no one said, no, they can't. I'm going to proceed. So I'm going to split this roughly into 2/5, preeclampsia and fetal growth restriction and biomarkers. I've got about 45 minutes to 50 minutes to talk, and hopefully we can take questions in the chat or questions live at the end. Okay, so let's start where most textbooks start when they talk about fetal growth restriction and preeclampsia, which is these lovely pictures of the placenta, placental circulation, the maternal side of the circulation, and the fetal circulation. And this is apparently where preeclampsia and fetal growth restriction starts. And when I was a young researcher at King's, working for Sir Campbell and then Kipros, in fact, that was very much what we thought, that this is all to do with the placenta. This is a placental condition. And then if we look at very nice reviews like this one from Lucy Chappell, Kathy Kluver, John Kingdom, Steve Tong and friends from 2021 in The Lancet, we looked at, you could look at all the predisposing factors: genetic, maternal, high BMI, comorbidities, hypertension certainly is predisposing factor, placental disease, immune factors. We all know about SLE and other conditions, antiphospholipid syndrome, multifetal pregnancy, preeclampsia, growth restriction, more common in all these conditions. And then these very scary symptoms and signs at the bottom, ranging from stroke, renal disease, hepatic capsular rupture, HELP syndrome, low platelets. So I won't go over all those because you know all these, but the point here is that preeclampsia is a multi-system disease, and it is predisposed by many different factors, and it still is not properly understood. And you'll see there in the middle this little panel talking about low PLGF, high S-FLIT, high soluble endoglin being associated with the syndrome, or the vascular aspects of the syndrome. I'm going to take us back a few years, and this was a paper by Ivo Brozens, a preeminent placental pregnancy researcher back in the 1960s. This is a reprint in the American Journal from 2019. It's a reprint of a 1960s paper looking at spiral artery remodeling in relation to the great obstetric syndromes. Now, this won't be a surprise to many of you. This whole concept of the spiral artery being remodeled in pregnancy between 8 and 16 weeks, becoming much less tortuous, quite dilated, higher flow, rather than the very spindly, thin, high resistance to flow spiral artery that you see at 8 weeks. So you can see here the intervillous space, the spiral artery, the decidua, and then the spiral artery feeding into the radial artery and the arcuate artery, feeding from the arcuate and radial arteries in the myometrium. The problem is that this classic description of spiral artery adaptation and trophoblast invasion, though beautifully described, doesn't always hold true. And it became very clear, I think, in the last 20 to 25 years, that although this is a component of abnormal placentation, or rather abnormal placentation is associated with abnormal trophoblast invasion, that certainly isn't the whole story for preeclampsia and fetal growth restriction. But we can see really nice images here, histological images of the marked distension and replacement at the top of the muscular and elastic tissue by fibrinoid and invaded trophoblast, and that is normal. And at the bottom, you've got a spiral artery in the myometrium of someone with severe preeclampsia, showing, if you can see, a really muscular swirly pattern showing untransformed spiral artery. Again, this is from back in the 1960s, republished in 2019, well worth a read. Anyway, all this led us to believe, certainly in the early mid-1990s, when we started looking at uterine artery Doppler, that what we were seeing in abnormal uterine artery Doppler, or the failure of transformation from between 8 weeks and 16 weeks, we were seeing high resistance in the placental circuit because of abnormal spiral artery development. And you can see here, and I've circled them, the uterine arteries at 8 weeks, uterine arteries at 16 weeks, during which you would expect to have a reduction in impedance and resistance in the uterine artery circuit. And in fact, that is what happens. But that is what has always been ascribed almost exclusively to spiral artery changes. Now, I will slightly embarrass Professor Nicolaides here, because it was really Kypros Nicolaides and Stuart Campbell in the late 80s and early 90s that led the field on much of this work in terms of uterine artery resistance and its relationship with adverse outcomes. And we moved, for many of you, you just won't know a world before color Doppler, but there is a world before color Doppler when we were using pulse wave Doppler. But when color Doppler came along, it transformed things, because it meant you could not only see the vessel, the uterine artery vessel there in the middle panel, but you could actually place a gate directly over it, and you could very accurately then measure the impedance in it. And this is a paper from Kevin Harrington in the early 1990s showing that notched uterine arteries, bilateral notches, high resistance, were strongly associated with prediction of preeclampsia and related complications. So it was very clear then that abnormal uterine artery Doppler was associated with abnormal outcomes. And following on from that, many papers from the King's Group, from Stuart Campbell and Kypros as well, showed that uterine artery Doppler, whether you did it in the second trimester or the first trimester, and this is a second trimester model working together with Mauro Para and others, we looked at the impedance, and it was as strongly associated with likelihood ratio for severe adverse outcomes. So that was severe preeclampsia and severe fetal growth restriction. Interestingly, the risk of someone being a smoker was double the risk of someone not being a smoker, but we were able to construct likelihood ratio curves for the first time based on uterine artery Doppler. And it was all really this theory of abnormal placentation associated with abnormal spiral artery adaptation. But at about the same time, there were various papers that suggested, yes, there was abnormal spiral artery adaptation in hypertension and fetal growth restriction. But actually, there was a pretty poor correlation between that and adverse outcome and that and Dopplers. So it certainly wasn't a very clear story. And I love showing this image of uterine artery. Now, I'd ask you all to, wherever you are in the world, to sit and look at this image. And this is an image at 27 weeks. Assume you'd say to me, probably these uterine arteries are normally transformed. They look normal. Well, I certainly would. But it's a trick question, because this was an abdominal pregnancy. So in an abdominal pregnancy, you don't have placenta, and you certainly don't have spiral arteries. So I'm getting at is you can transform vessels without spiral arteries and a placenta. And this is the reference of the paper from Placenta in 2011 from the Oxford group. So really, this is a question about belief and understanding, and whether the Earth revolves around the sun or the sun revolves around the Earth, or, as is often the case, a little bit of both. So now let's move from those early theories of preeclampsia development, abnormal trophoblast invasion, abnormal placentation, abnormal placenta, therefore developing preeclampsia and growth restriction. Let's move to a subtly different area of research that at the time was quite separate and has only much more recently coincided, which is cardiovascular changes in pregnancy. So we know that cardiovascular changes are important in development of preeclampsia and growth restriction. We also know from systematic reviews and data from prior to pregnancy in big studies that the more hypertensive you are prior to pregnancy, the higher your risk of preeclampsia or growth restriction. And abnormal hemodynamics in the first trimester is associated with preeclampsia and growth restriction. So there is clearly an association with abnormal cardiovascular function in the mother, even potentially before pregnancy, and the development of preeclampsia and growth restriction. But this is where we've sort of been let down, because again, if we go to page 2 of our textbook, I showed you page 1, which was the placenta, page 2, cardiovascular changes in the maternal circulation in pregnancy. Have you noticed how all of them don't really start in the first trimester? They only start in the second trimester. So we lose out this area in the first trimester because no one's really looked at it. Because, and I'm as guilty as many or have been, because for us as fetal medicine doctors, it all starts at about 11 or 12 weeks. But actually, there's 8 weeks before you get to 12 weeks where quite a lot could be happening in the mother's circulation. This was first shown by Chapman and others in the late 1990s in Kidney International. And these are the changes in mean arterial pressure, cardiac output, vascular resistance. This is about 6 or 7 weeks. Can you see there are very profound changes in cardiac output, mean arterial pressure, and vascular resistance dropping or SVR dropping, cardiac output increasing, mean arterial pressure dropping in very early pregnancy in women who just had spontaneous pregnancies. So it's actually quite easy to look at hemodynamic changes. And I'm just showing you some of the testing mechanisms methodologies that we used over the last 10 or 15 years. There are lots more and lots of good tests that I haven't shown here, but these will tell you about arterial function, cardiac output, vascular resistance, exercise tolerance, and all sorts of very important things that tell us about maternal cardiovascular health. So if we use these tests and look in early pregnancy, as Amita Mahendru did, working with me in Cambridge just over a decade ago, she found that at about 5 or 6 weeks, for instance, let's look at arterial function. This is augmentation index. There have been a very dramatic reduction within 1.5 weeks of a pregnancy test being positive in healthy women. So there are profound changes within a few days or a week or two of a positive pregnancy test. This was redrawn from Amita Mahendru's paper and is in circulation in 2014, again showing that cardiac output and vascular resistance are changing really from very early pregnancy. Certainly very significantly to the second trimester, but you can see changes as early as 6 or 7 weeks. Which takes me on to what I think is a really fascinating study, and this was run by Lin Fu with my group and published in Hypertension in 2018. And Lin and Amita took about 500 women who were trying to get pregnant. So they're healthy women, and we tracked them very carefully through the early period of their conception and pregnancy. So we had no idea of what their outcome was going to be until obviously after they'd had their babies. And what we found, very surprisingly, was that the women who are ostensibly completely healthy, have normal blood pressures, normal BMIs, they don't have anything else to mark them out. But those that develop preeclampsia growth restriction had a lower cardiac output and a higher vascular resistance than those that didn't develop those conditions. And I really want to emphasize that these are women who might be sitting in front of you in a clinic asking you about advice prior to getting pregnant, and they'd look completely normal. And you do their blood pressure and they're completely normal. Their blood BMI would be completely normal. But you would only know about their risk if you actually looked at cardiac output, vascular resistance, and potentially arterial function. We followed many of these women through pregnancy and constructed ranges for cardiac output and vascular resistance using different methodologies. And this was published in Heart in 2020 and allowed us to show that actually the changes in cardiac output and vascular resistance happen very much earlier and peak very much earlier than we thought they did. To previously, it was thought 26 weeks was peak cardiac output. In fact, we found it was 16 to 20 weeks because we had more frequent sampling intervals. So anyway, where do we go from there? Well, challenging the conventional wisdom, maternal cardiovascular changes are really present in early pregnancy. Cardiac output may peak in the mid-second trimester and much earlier than we thought before. And low pre-pregnancy cardiac output and high vascular resistance in otherwise healthy women is associated with preeclampsia and fetal growth restriction, particularly the combination of those two. So then we come to another conundrum that has caused immense confusion for years and years and years. And I'm not surprised if you get confused because reading the papers, they say different things. Is cardiac output high, low, or normal in preeclampsia and fetal growth restriction? And the difficulty here is that preeclampsia at 26 weeks is quite different to preeclampsia at 36 weeks in terms of cardiovascular profile. And the mother's cardiovascular system works differently. So you can't compare a preeclamptic woman at 26 weeks to a pregnant woman with preeclampsia at 36 weeks. Let's look at Tom Easterling, one of the classics in hypertension in pregnancy. One of the first papers in this area of Set Gynecol in 1990, showing cardiac output was elevated throughout pregnancy in patients who became preeclamptic. So this was following women throughout pregnancy, so elevated cardiac output. Let's go to one of the St. George's Group, Baschi, Karen Melchiori papers that showed the part of the graph I've highlighted there are the women with preeclampsia and growth restriction, so early onset severe disease. These women had very high vascular resistance and very low cardiac index. Can you see that? So we've got one paper suggesting cardiac output is high. We've got this paper here suggesting cardiac output is low in preeclampsia. That is confusing, but not as confusing as if you read this review, which tells you that preclinical phase is characterized by high cardiac output, but then you get a low cardiac output, and then you get a reduced cardiac output, but you get an elevated cardiac output. So how can we explain what is a pretty confused area? And my point is that maternal cardiovascular changes in preeclampsia are confusing and cancel each other out because there are two ends of a spectrum and they're diametrically opposite. And if you cancel out opposites, you end up at the median of 0. And this is where we go to some really nice work by Herbert van Aziz in Rome and his group, Barbara Vassapolo and Giampaolo Novelli, who looked at women with preeclampsia across a gestational range. And let's just look at that slightly complicated scatter plot at the top right. And I've helped you a bit by drawing a red circle around those on the right-hand side and a green circle around those on the left. And can you see at the top there, there's a line that says TVR dynes per second per centimeter to the -5. That tells you about vascular resistance. So there's some women with preeclampsia who have a spectacularly high vascular resistance of 1600, 1700. And these same women have a very low cardiac output. Can you see that of 3-4 liters a minute? And this is a consistent finding, interestingly, in pregnancy. And I talk to cardiologists about this, and they say this is simply impossible. You cannot have adults walking around with a cardiac output of 3 liters a minute. And I say, well, we do, because we do this with echo, we do this with other methodologies, and we get very low cardiac outputs in these very hypertensive women. But there's another group to the right, the orangey red group. Can you see that little oval there that delineates women with hypertension who have a very high cardiac output, 8, 9, 10 litres a minute. That's huge. And actually a remarkably low vascular resistance. What's this telling us? It's telling us that actually there are two isoforms of preeclampsia. One with high vascular resistance and low cardiac output, and one with low vascular resistance and a high cardiac output. So what's the difference between them? I'm going to show you the difference between them is fetal growth restriction. Women with preeclampsia and fetal growth restriction almost invariably have high vascular resistance and low cardiac output. And women with preeclampsia without vascular resistance, without fetal growth restriction, tend to be at or close to term, and they tend to have babies that are normal size or even quite large. So let's look back at Herbert's paper, and if we have late preeclampsia and early preeclampsia in those columns, you can see those. You can also see that the late preeclampsia women had much less frequent uterine artery notches, whereas the early preeclamptics had far more frequent uterine artery notches. And this is a consistent theme that uterine artery Doppler, we know, is much better at picking up early onset and severe complications. The neonatal weight centile, not surprisingly, was much higher in late preeclampsia than it was in early preeclampsia. So this is all beginning to fit together. I should just credit Enrico Franzi and his team, 2016, who stumbled across the same idea doing a completely different study of bedside diagnosis of fetal growth restriction. But we tried to work this out for ourselves here at Imperial, and we thought, well, we're not going to look at early and late, we're just going to look at the entire gestation range. But the problem is that many of the original studies didn't control for fetal growth restriction, so they just lumped all preeclampsia together. So you get preeclampsia with a woman at 26 weeks with a baby of 460 grams, and preeclampsia at 38 weeks with a woman with a baby with 4.2 kilograms. They're clearly completely different types. And because early onset fetal growth restriction is strongly associated with preeclampsia, you have to control for that. I mean, I don't know why this should be the case, why later onset should be less associated with fetal growth restriction. I have no idea, but it is. So Jasmine Tay, working here at Imperial with Lin Fu and with me, did a study, longitudinal study, where every woman coming to Imperial with preeclampsia or growth restriction was eligible to take part. So she scoured the labour ward and the antenatal wards every day when she was doing her PhD. We constructed normal ranges for cardiac output, vascular resistance, pulse wave velocity, because we didn't want to assume that it was the same at 26 weeks as 32 weeks as 36 weeks. And we therefore allowed ourselves the luxury of normalizing every measurement we got to that gestational range. Now, I hope this hasn't been too statistically challenging. It's exactly the same as you do with nuchal translucency. It's different at 11 plus 4 weeks to 13 plus 6 weeks. It's called normalizing. It's exactly what you do with multiples of median, MOMs, of hormones. They are different at different gestational ranges. But bizarrely, they hadn't been done across a gestational range before. Now, this is back in 2018. So it removed the effect of gestational age on parameters. And the moment we do that, we can then compare preeclampsia right across the gestation range, as long as we call it preeclampsia and don't include FGR. We can include preeclampsia and FGR if we call it preeclampsia and FGR, and that's what we did. So we had pure preeclampsia, pure FGR, preeclampsia with FGR, and control women. And what did we find? We found that in women with preeclampsia alone, cardiac output tended to be raised. In women with preeclampsia and growth restriction, it tended to be low, whatever gestation you were. Vascular resistance, exactly the other way around. If you had preeclampsia but no growth restriction, the vascular resistance tended to be low, and it tended to be high if a woman had preeclampsia and fetal growth restriction, which actually in retrospect fitted extremely well with Herbert Valenci's work and Baski and Karen Melchiorre's work from almost a decade before. I'm going to talk for a moment about arterial function augmentation index, which is about smooth muscular function, pulse wave velocity, more about the recoil of the vessel. And all I can say is that whether you've got early or late preeclampsia with growth restriction or not, arterial function is very disordered, whatever you have. So there's definitely an endothelial problem. It's just that cardiac output and vascular resistance go in opposite directions. So this is a handy little reckoner, I think, just explaining which direction cardiac output and vascular resistance go in which conditions. It is all incredibly intuitive, but you'll need to look at this a few times before it becomes very, very intuitive. I should just say that at a very similar time, Jasmine published her work in AJOG. Daniel Stott, Nick Kometas, Kipros, and others published very similar work in UOG, finding that low cardiac output was prevalent in preeclampsia with growth restriction. And they made this very important comment. Clinicians treating women with preeclampsia and growth restriction should avoid compromising an already suppressed maternal cardiac output by careful titration of antihypertensives. Why is this important? Well, if we've got a very hypertensive woman who's really shut down with very tight blood vessels and she's got a very low cardiac output, you don't particularly want to give her antihypertensives that will knock off the cardiac output any further. And I should also say Wilfred Giesler's working at this from a slightly different direction, looking at women longitudinally from 11 weeks, has found a very similar thing as well. Early onset preeclampsia associated with the most severe cardiovascular disturbances. And also he's seen a situation where women with high output preeclampsia end up having low output low cardiac output if the disease is in its very late stages. But I'll leave that for a moment because that's a special situation. So just to hammer the point home again, early onset preeclampsia associated with FGR, low maternal cardiac output and high vascular resistance. And the opposite is true for preeclampsia without fetal growth restriction, where there's often a high cardiac output and low or normal vascular resistance. Many of you here on this webinar will be doing fetal medicine, fetal maternal medicine, and obstetrics, and you will be prescribing women treatments for their hypertension preeclampsia. So is what I've said in the last 10 or 15 minutes remotely relevant to your practice? Now, firstly, I'm not going to pretend there are any proper good studies yet looking at different antihypertensives in different cardiovascular subtypes of preeclampsia. We don't yet have that. But given that we have a number of different drugs that we can use in preeclampsia, it makes sense to consider using the one that pharmacologically most fits the phenotype of the condition you're dealing with. So I've said already, preeclampsia exists as two phenotypes. The terms early and late preeclampsia I don't particularly like, because you can have early preeclampsia with a normally grown baby with a woman who has a high cardiac output, although it's rare. You can have a woman with late preeclampsia with a very severely growth restricted baby, and in that case should have a low cardiac output. So although late onset preeclampsia is much more strongly associated with high cardiac output, low vascular resistance, it doesn't mean that that woman could not have a growth restricted baby. So what I'm really saying is the key discriminator is growth restriction. Okay, so just remember that, because that's why you as fetal medicine doctors, midwives, sonographers are so very important, because women with preeclampsia really do desperately importantly need to know if the baby is small or big. This paper was published just 2 years ago in the American Journal, and has some nice schematics in it that I think are useful in understanding the conditions. Enrico Ferrazzi and I wrote this piece back in 2017, The Relevance of Hemodynamics in Treating Preeclampsia. We make the point here, I'm not going to go through every bullet point, but the blood pressure is pretty crude. I mean, it's an end result of lots and lots of changes. And actually what you want to know is cardiac output, intravascular volume, vascular resistance. That's much more, well, it's not much more important, because of course blood pressure is important because it is strongly associated with end organ damage, but it's really the components of blood pressure that are the critical things. So we say there, knowing the underlying type of hypertension allows rational treatment rather than controlling BP by any means possible, as an end in itself. And I've taken this from two references. One is Mark Spanderman. The other is Giulia Massini and Barbara Vazopolo. So this is a sort of understanding of when you might treat different types of preeclampsia with different drugs. And they split into two groups, really. The vasodilators, which are calcium channel blockers, nitric oxide donors, and the alpha and beta blockers that tend to reduce slightly cardiac output, but don't primarily work by vasodilatation. And we recommend that you use vasodilators where it is highly likely a woman has a very high vascular resistance. But just be a bit careful, because if you vasodilate a woman with very high vascular resistance, she may have reduced intravascular volume and you could end up crashing her blood pressure. So you've got to be careful to make sure she's fluid replete before you do that, which of course is a potential issue in itself, because these women are also at risk of pulmonary edema. So I'm not selling a simple therapeutic strategy here, but I'm asking you to think about therapeutic strategies, and you can do that in the context of this sort of schematic and try and target the right treatment to the right woman. Just before I move on to fetal growth restriction, which is the second major part of this talk, I just want to show you that in women with preeclampsia, growth restriction, fetal growth restriction, and preeclampsia, you can see here that cardiac output, the higher the cardiac output, the lower the uterine artery Doppler impedance, and the higher the vascular resistance. So if you have a very high cardiac output, Z score, you tend to have a very low vascular resistance, Z score, in the uterine arteries, which is, I think, really interesting. And you see exactly the same in the umbilical arteries. So what am I trying to say here? Well, actually, the maternal cardiovascular system seems to be modulating the fetal, at least the fetal umbilical artery circuit. And we found exactly the opposite relationship with the middle cerebral artery. So it is at least plausible that the mother's circulation strongly influences the fetal circulation, and that fetal Dopplers are to some extent a manifestation of the maternal circulation. So now let's move not to something completely different, but to the next step in this story, the next chapter, which is growth restriction. And I really like this schematic that we put in a paper in the American Journal just over 2 years ago, which is, and of course it's nonsensical to say that FGR at 31 weeks is completely different to FGR at 33 weeks, but there are subtle differences. And as I've explained, many of the women with earlier FGR have preeclampsia and have very disordered maternal cardiovascular function. And they also have babies with very, very clear Doppler signs of deterioration. So in many ways, early growth restriction is actually quite easy to pick up and manage, because the Doppler features are reasonably consistent and change with time in a largely consistent manner. Fetal growth restriction greater than 32 weeks is less associated with profound Doppler changes, less associated with profound maternal changes. And the babies, of course, aren't always very small, but there's still the same risk of, or there's still a risk of stillbirth, and abnormal biophysical profile, reduced movements, reduced amniotic fluid just prior to delivery needing to take place. So let's talk about the definitions of early and late growth restriction. Many of you will know this. This is the Delphi consensus. Some subtly different changes between early and late definitions, but essentially most babies that will score on less than 32 weeks will score on greater than 32 weeks in terms of the definition of growth restriction. I'm going to separate this out into time to delivery and timing of delivery. So what do we know about time to delivery? Well, let's look at early growth restriction first of all, the Truffle study, 26 to 32 weeks. And by looking at 500 very early growth restricted babies, we were able to see that the difference in death rate and morbidity changed very dramatically with gestational age. So if you made a diagnosis of FGR at 28 weeks, there was a 10% perinatal death rate and 50% severe morbidity. But of course, you won't be delivering that woman at 28 weeks. You'll wait 2, 3, 4 weeks. Let's say you wait another 2 weeks. The graph changes to the graph at 30 weeks. So this is now delivery at 30 weeks. So you've counseled a woman on diagnosis at 28 weeks, got a different chart now, delivery at 30 weeks, the perinatal death rate has halved, and severe morbidity has reduced. So this is about time to delivery. So it's really important to wait if you can. And if you find that the woman has hypertension, particularly severe hypertension, that curtails the time to delivery. So the worse the hypertension, the more likely she is to deliver early. And 3 days, within 3 days of diagnosis with HELLP syndrome, about 2 weeks if she hasn't got high blood pressure. Those are the median times. We've looked at our Truffle 1 and Truffle 2 data such that it is today, which is about 6,000 women. And we find that hypertension, look at the red bars here, preeclampsia, PIH, hypertension significantly shortens the time to delivery over all gestational epochs. The really interesting thing, and we hadn't quite expected this, is that you get the longest time to delivery in the 32 to 34 week group, mainly because at less than 29 weeks, at 29 to 31 weeks, it's usually severe disease and the women can't be kept going for very long because they develop severe preeclampsia or the babies develop severe Doppler changes. At 35 to 36 weeks, well, it's only a week to go till 37 weeks, so most women are delivered anyway. So the longest time you can wait seems to be with those babies at 32 to 34 weeks. Interesting. Hadn't known that before, but it's an interesting observation. So certainly there is value in these women at 32, 33, 34 weeks being monitored closely, getting them a little bit further along in their pregnancies. So what about vaginal delivery and gestational age? Well, this is probably the best data we have. Truffle, so early onset growth restriction, virtually all babies were born by cesarean sections. Grit was 24 to 36 weeks, and about 15% had vaginal deliveries. And then we get to Truffle at 32 to 36 weeks, about 60% vaginal deliveries, and Digitat about 85 to 85% had vaginal deliveries after 36 weeks. I don't think that will be the case now. But now let's talk about timing of delivery. Let's talk about early growth restriction, timing of delivery. And this is all about really the ductus venosus and the CCTG. So we know as the ductus venosus becomes more abnormal, the risk of adverse outcome, the likelihood that you'll need to deliver becomes higher. And we wait until there are late ductus venosus changes because in Truffle, in the late ductus venosus group, 95% of women had normal or had babies that had surviving babies that had normal or near normal neurodevelopment, 95%. Those that were randomized to CTG, 85%. So still a high percentage, but the highest percentage of normal or near normal neurodevelopment, 26 to 32 weeks, was in those women who were managed according to late ductus changes, or I should say abnormal CCTG. So that's really important. So early fetal growth restriction, uterine artery, I always do it because I'm interested in it, but it doesn't really time your delivery. Middle cerebral artery, certainly not time delivery. Umbilical artery Doppler, yes, beyond about 30 weeks, 32 weeks. Ductus venosus, yes. CCTG, yes. And knowing timing of delivery allows you to optimize timing of steroids, give magnesium sulfate, and monitor with CTG, decide if you're going to do a classical or lower segment cesarean section, and of course get the baby into a position where there's neonatal attendance. This is a woman who I saw some months ago, early in 2024. So she's paranaught, 31, NIPT, low risk, negative viral infection parameters, and the baby was tiny at 20 weeks. Placenta looked awful, as you can see. At 27 weeks, the baby reached 481 grams, but that placenta does look pretty terrible. 27 plus 6, the ductus venosus PIV was raised. There was umbilical reverse end-diastolic flow, oligohydramnios. So according to Truffle, DV, PIV raised, yes, we would be delivering very soon. Umbilical reverse endoscopy. You could wait if the ductus was still normal. She's given steroids. She was started on magnesium sulfate, and early that morning, look at the CTG. So this is why the computerized CTG is important, because she started decelerating. And you can see there that the short-term variation was borderline and there were decelerations. So don't ever forget the CCTG. And this is, again, as I say, back in June, July last year. And the baby was born weighing 496 grams. So we're quite close on the weight. And the baby did remarkably well and went home. And I'm going to show you this schematic at the end, but this is the left-hand side of the ISWOG schematic, which takes you from 24 weeks to 34 weeks, and it covers both the ductus venosus and the CCTG, but also it explains about the umbilical artery Doppler too, which really comes into play after 30 weeks. Late growth restriction, a little bit different, because we're looking at size, but we're also looking at growth, so growth drop off. And we know that umbilical artery Doppler, for whatever reason, is associated with reduction in perinatal mortality. We know that from work nearly 30 years ago, and work more recently from Cochrane Review that suggested that umbilical artery Doppler is associated with a reduced risk of perinatal mortality. What about cerebral artery Doppler though? Because everyone gets very excited now about cerebral artery Doppler. But what I'd like to say is the association between abnormal cerebral artery Doppler and adverse outcome isn't the same as prediction. So there are lots and lots of papers showing that there's a strong association between abnormal cerebral artery Doppler and adverse outcome, including this paper from the St. George's Group in 2018. The red hashed line here is associated with perinatal mortality. But there is no prospective or evidence to inform timing of delivery and management using cerebral Doppler. So late fetal growth restriction, what do we use? Well, we don't use the uterine artery and we don't use the ductus venosus, really. We do use the umbilical artery Doppler. We use the middle cerebral artery insofar as it defines growth restrictions. So beyond about 37 weeks, if you have a growth restricted baby, you'll probably deliver the baby. So it's really more for definition rather than direct management. But we do use computerized CTG as well. Now I'm going to divert to one or two slides on the truffle feasibility study. We haven't quite finished the randomized study, but we got some interesting data from the feasibility study that ran between 2017 and 2018. And this showed that in late growth restriction, so 32 to 37 weeks, the association with adverse outcome was well, there was an association between birth weight and adverse outcome, but the strongest association was with gestational age at delivery. So by far the most important thing is to try and prolong pregnancy if you at all can, even at 32, 33 weeks. And this, of course, gets you into the position where you can now decide induction of labour or caesarean rather than classical caesarean versus lower segment. Still want neonatal attendance, may give magnesium sulfate up to certainly 32 weeks, possibly even 34 weeks. And we would give steroids up until 35 weeks. And this is that part of the ISWOG guideline that just tells you about later growth restriction. And you can see we're moving away from ductus venosus and towards umbilical artery Doppler. And after 38 weeks, if there is redistribution, I think it's reasonable to deliver the baby. Some references here, the ISWOG guidance from 2020 that we're actually rewriting. We're just about to start rewriting it at the moment. And the very long in gestation RCOG guidance from 2024, published in 2024. I'm particularly proud of this joint effort from the authors on this schematic here, which is based loosely on the ISWOG schematic. It says more or less the same things, but in a slightly different way. So please do leaf to the end of that guideline and you will see what I think is quite a useful thing to pin up on your wall, because it tells you about how to manage based on different gestational age ranges. Now, I think have I got about 3 or 4 minutes left? think so.
Okay.
Yes, of course. Yeah.
Yeah, brilliant.
Please carry on. Yeah.
Thank you very much, Kipros. Let's just talk about biomarkers, because I always get questions about biomarkers, and the short answer is we don't quite know yet, but they're looking interesting. And some of the early papers from about 10 years ago, this is 2016, in women with FGR babies, showing that the lowest PLGF, can you see the black there, lowest PLGF was associated with the most shortest time to delivery here, and normal PLGF a much longer time to delivery in growth restricted babies. Also showing that those pregnancies affected, can you see the red, the little red diamonds here, affected by the worst placental lesions. Can you see red, 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 were associated with the lowest PLGF levels. So there's certainly an association between low PLGF, placental lesions, and adverse outcome. And I'm just going to show this paper because it sprung into my inbox just a couple of days ago in Nature Medicine. I'm not going to pretend I'm not very jealous at all. Angiogenic factors versus feto-maternal Doppler for fetal growth restriction at term, an open label randomized study of 500 women roughly in each group from a Spanish group, Aldehebron, showing that that using biomarkers, SFLT-PLGF, versus using standard Doppler and estimated fetal weight based algorithm was non-inferior. So suggesting that at term you could use biomarkers and SFLT-PLGF ratio to determine delivery timing, and that was no worse than Dopplers, which is an interesting approach. I think it doesn't necessarily show the optimal management pathway, but it certainly shows that using Dopplers at term it was not worse than just booking induction based on the Doppler and estimated fetal weight that you had generated from a scan at 36 or 37 weeks. There is a bit of a fly in the ointment here, and I mention it every time we have biomarker papers, and it comes up time and time again, that in the intervention group based on biomarkers, the preeclampsia rate was 0.4%, whereas in the control group managed according to Dopplers, it was 2%, which is quite interesting because the issue is that we don't know how much SFLT-PLGF is telling us about the actual health of the baby or the health of the mother and the likelihood of preeclampsia developing. So my point here is that studies reporting SFLT-PLGF don't adequately control for hypertension. I'm going to show you now 3 slides on Truffle2 data from the last 4 years. So this preliminary data, not published and certainly not final, but quite interesting. So does SFLT-PLGF, so let's focus just on SFLT-PLGF. We've looked at other biomarkers, but just SFLT-PLGF. Does it tell us the difference between healthy controls SGA and FGR? The answer is there are some differences there, as you can see, but they get strongly attenuated with when you remove the hypertensive women. So differences are attenuated in normotensive pregnancies. What about adverse neonatal outcome? Well, you could say there's a little bit of a clue there. SFLT-PLGF, higher the ratio, more likely adverse outcome. There's a huge overlap there, so doubtful it would ever be clinically useful. But that effect is virtually abolished once you stick to normotensive women. So SFLT-PLGF is strongly telling us about hypertension-related morbidity, and not very much else here. Time to delivery, possibly slightly more promise here with SFLT-PLGF because there's still a difference. Well, there's statistical significant difference anyway in normotensive women anyway, but I think the message here is that we've got to be quite careful because unless we tease out the relationship of SFLT-PLGF with hypertension, we could end up getting confused with what is a hypertension effect and what's a genuine effect of morbidity due to other causes. We've tried putting together the most important predictors in a model for time to delivery, and we find that umbilical cerebral ratio, estimated fetal weight, and SFLT-PLGF ratio does give a prediction with an AUC of 0.87, but the odds ratios are really not very high. So I would not, I'm not trying to sell this to you as a good model at the moment, but there's potentially promise in using umbilical cerebral ratio, estimated fetal weight and biomarkers to stratify care, not necessarily to individualize care. So here we are. Let's finish that mammoth preeclampsia growth restriction guidelines and biomarker talk with preeclampsia exists in two phenotypes with opposite cardiovascular findings, and the discriminator is coexistent FGR. Preeclampsia is associated with maternal cardiovascular changes prior to pregnancy. I've talked to you about early fetal growth restriction, less than 32 weeks, and the management of it, and the subtle differences in cardiovascular function for the mother compared to late. And I think it's important to consider biomarkers, but also to understand that their role is certainly not defined yet. There are differences in biomarkers between normal pregnancies, SGA and FGR, FRES, FLIP, PLGF, but they are much less pronounced when you take hypertension out of the equation. It may be that there's interesting data in respect of time to delivery and adverse outcome, but to be quite frank, the ranges overlap very largely, and we have looked at many different prediction models, and the performance is modest, and again attenuated when normotensive pregnancies are analysed. And I think that's where I will conclude. Thank you.
Well, Steve, that was a brilliant talk, a massive talk covering both preeclampsia, pathophysiology, and fetal growth restriction. I think it's a beautiful beginning to this series of lectures put up together by Steve Thornton. I don't know whether Steve wants to make any comments, but let me tell you all that this lecture has now been recorded and it will be available in the Fetal Medicine Foundation website for you to think through again. The only comment that I would like to make, Christoph, is exactly the same one as you did at the end of your lecture in relation to the PLGF and the FLIT. I think they are very good biomarkers, especially at that stage for preeclampsia, but not so for fetal growth restriction in the absence of hypertensive disease. I fully agree with that. Steve, are you there? Do you want to?
I am here, and I'd been on Teams all morning, and it worked perfectly until the whole system went down just as we were about to start. So apologies for not introducing you, Christoph. I was going to say a couple of things about the lectures, and then we'll come on to questions for you, if that's okay. And first of all, we had an absolutely amazing response with 1,000 people registering, and that stopped a lot of people joining because we limited. So for next time, we will remove that cap on the numbers that can join. I will also, as Kipos said, put it on the website, so that will be useful, and I will send something around to everyone to let them know. So apologies about me not being there, and apologies that I know that you've all joined, but apologies to those that couldn't join, and there were quite a lot of people. So can we have some discussion about your talk, if that's okay, Chris? So in terms of, you've nicely talked about growth restriction and how that's a discriminator. You also talked about the cardiac output and the other vascular parameters. And what I'm trying to get my head around is, for those of us that walk onto delivery and see women with preeclampsia or manage them in the antenatal clinic, should we be doing additional tests, as additional cardiovascular testing? And how does that actually make a difference? So is there a simple message? You showed that the slide which talked about the different hypotensive. Is there a simple message so that we can think, these are the tests that I need to do now, knowing these different phenotypes, and this is the treatment I need to give in a particular phenotype?
Yeah, I think that's incredibly practical question that probably confronts most of us on many of the days of the week when you're confronted with a hypertensive woman. Let's just leave additional testing methodologies out for a moment. And if you buy the general argument that a woman who has a growth restricted baby generally is most like, if she's got hypertension and a growth restricted baby, she is very likely to have a lowish cardiac output and a high vascular resistance. She's basically that's almost certain. And then we go to NICE, which is frankly pretty agnostic on what whether you use labetalol or nifedipine or whatever. You've actually got a degree of flexibility to decide what you're going to use. So if I do see someone on labor ward who's got growth restriction and preeclampsia, I will use as my first line nifedipine. If I see a woman at 38 weeks with a baby that's, you palpate the baby or you do a scan and the baby's 3.9 kilograms and she's sort of got, her veins standing out on her forehead and clearly full of fluid, intravascular fluid, I'd almost certainly give labetalol, because that does slightly take the edge off cardiac output, and that's probably the right treatment for her. And I don't think that's a danger. That doesn't fly in the face of any guidelines, because most people would choose those antihypertensives randomly anyway. Now, that's part one. Part two is if you are able to do cardiovascular assessments, then that does then you suddenly start seeing what these phenotypes look like, and you get, it's really interesting. I had a woman 2 weeks ago who had really severe early onset fetal growth restriction, about 27 weeks, and she had a vascular resistance that was 90. No, it wasn't. It was 2,200. It was just spectacularly high at a level that most cardiovascular physicians say, it shouldn't exist. And she had a cardiac output of 3.1. Now, whether that was correctly measured by, we used two devices there or not, clearly she had a very disordered cardiovascular function. Now, what would I use there? Well, I'll tell you what Herbert Valencis would use in Rome. He would probably admit and very carefully replace her intravascular volume, and at the same time give her calcium blockers and glycerol trinitrate. Now, I've got to emphasize for everyone here, that is, that's not standard treatment. That's experimental treatment that you undertake with very, very careful titration of the mother's circulation. But the point is that it is possible to tailor antihypertensives, just very simply in the way I said first. And then secondly, if you're in a center where there is expertise with non-invasive cardiovascular assessment, to start talking to anaesthetists and other experts around about how this can help your management of the condition. I should say that the RCOG spent years not particularly interested in this, and to give them their credit, we've just finished a SIP on exactly this. I think Steve, actually, because I think I saw your name as a reviewer, and it was good because it is, for preeclampsia, it's a dangerous condition. You can't have people doing all sorts of different things, so you've got to think very carefully about this. But I think we're putting the case that it is important to think about this and to understand a bit more about it, rather than treating everyone in exactly the same way. I hope what I've said isn't heretical, but makes sense.
Christoph, we have a question from Dr. Vias, 37 weeks, healthy person. The baby is below the 10th centile with normal Dopplers. When should she be delivered? 37 weeks, normal Dopplers, SGA.
All right. So I'm taking it's a non-hypertensive woman, 37, just let's say ninth percentile. Everything else normal. I would normally recommend delivery at 38 to 39 weeks.
I agree with that. And I think at that point, we will leave this fantastic webinar. Thank you to everybody for attending. And we'll see you again in a month. Steve?
Yeah, great. Thank you very much. Thank you all for attending.
Bye-bye.
Bye.
Bye.